It gives me great pleasure to introduce Dr. Swapnil Hiremat, who is currently staff nephrologist at the Ottawa Hospital, associate professor at the University of Ottawa, and associate scientist at the Clinical Epidemiology Program of the Ottawa Hospital Research Institute. Dr. Hiremat completed his DM nephrology from Mumbai before moving to Canada. He then completed his master's in public health from the Harvard School of Public Health. He has numerous papers and grants to his credit, but closest to his heart are systematic reviews and decision analysis. Many of you probably know him as co-creator of NEFJC, a hugely popular Twitter-based critical appraisal platform. He is as passionate about photography and gardening as about science and research. But today, he will speak to us about study designs, specifically observational studies. May I now request Dr. Swapnil Hiremat to begin his talk?
Thanks, Atul, for that very generous introduction. Let me just go back and start my presentation. Thank you again for that generous introduction, and thanks to the Indian Society of Nephrology for inviting me, and for all of you to take time out from your Saturday afternoon. It is still morning here in Canada, so you will see my drinking my cup of chai while I'm talking, so excuse me for that. As Atul alluded, I will be talking about observational studies, some basics and some biases. I do have a bunch of slides, but I think it makes sense that rather than me talking for a straight 75 minutes, that we can take breaks in between. There seem to be a lot of questions. I just got the tail end of Dr. Datta's talk, but there seem to be a lot of questions, and we can probably take breaks in between so that it doesn't become too much of a monologue. In terms of disclosures, I do not have any financial conflicts with any drug or device manufacturing industry. I do have some research funding support from the Canadian Institutes of Health Research and other agencies, as well as my university, which does support the research that I'm doing. And some objectives that I laid out for myself is after this hour, you would be able to possibly plan and lay the groundwork for doing either a case series or some kind of a retrospective cohort study or a quality assurance clinical quality improvement project. But more importantly, understand the different biases and pitfalls while you're doing these kind of observational research, and develop good practices while doing observational research. It's as much easy to have biases in your research. It is easier to do observational research possibly compared to doing a prospective cohort study, or more importantly, a randomized controlled trial. That doesn't mean that it makes it right necessarily. So just to go over, I'm sure some of the material will be overlapping with what Dr. Saurabh covered last week and Dr. Datta just covered. But there are many different types of research studies. And what I'll try to cover is, case series, cross-sectional studies, a little bit on cohort studies, either retrospective or prospective. And I'll just touch upon systematic reviews and meta-analysis. There will be a workshop later on in these series in October on systematic reviews and meta-analysis by Atul and I. So case series. Case series are very simple. It's not just one case report. It is having more than one case report. One patient makes a case report, more than one makes a case series. And it's often done when there is an epidemic, as is happening right now. And all you need to do is to provide descriptive characteristics of some kind of an unusual disease or some kind of an unusual presentation. And strictly speaking, there are no controls, right? So if you've got controls, it's either a case control study or it's a cohort study. So case series is just one kind of presentation, but you have multiple patients. Do you need an ethics approval for that? And what kind of analysis should you be doing in this? So this is kind of what and you may wonder, why should I do a case series? That's really at the near the bottom of the evidence pyramid that you might see, where people talk about, mechanistic studies perhaps, and editorials at the bottom, and then case reports and cross-sectional studies and case control being higher than case series, interestingly enough. And then come cohort studies and, with RCTs and systematic reviews right on the top. Or this is something you might see, which is, where you put in basic science studies at the absolute bottom, and clinical practice guidelines at the absolute top. Despite me doing a bunch of systematic reviews and writing a lot of guidelines, I would say this is not really true. These kind of pyramids are are made by people like me, who do systematic reviews and meta-analysis, and we like to say, hey, what I'm doing is the best. It's not necessarily true. It's sometimes true in some settings, but in many other settings, it may not be true. And we shall see some examples. For example, this is a case report. Some of you, I was still in, I don't know if I was even in high school when this paper came out in the New England Journal of Medicine. It came out in 1981, and it was the case series of 4 men, only 4 men. Nothing, the total sample size of the study is 4, and 4 men who were healthy. At that time, it was called healthy homosexual men who contracted pneumocystis carinii pneumoniae. Now it's called, of course, PJP and not PCP. And they also had mucosal candidiasis and had multiple viral infection. And the question was, are they having some kind of immune deficiency? And all of them were gay. So there was a suspicion about what was going on. And as you know, subsequently, this was the first report of what would then become the AIDS epidemic. This was before HIV was discovered. So these kind of things are possible, right? You are a clinician, you're looking at patients and something strikes you as being quite different than what you have seen until now. That might be enough. That might be enough to, write it up, and just the descriptive analysis. And that can be hugely relevant enough that the most important journal in medicine would be interested in it. This is another example from earlier this year. This was in February when they published the coronavirus stuff from China. Right now, of course, there is a lot of case series coming out with the epidemic. And that's the thing, right? So case series are often published when there is an epidemic, when there is something new and dramatic happening. We don't usually take care of our chronic kidney disease patients, and our patients with hypertension or on dialysis are not really like this. Can you write a case series about chronic diseases? And I will argue that it's absolutely possible. So this is from my alma mater, from where I did med school all the way to nephrology, from 1963. So Dr. Sain Kinnare, engineer, and Dr. Parulkar described what they at that time called the middle aortic syndrome, or aortoarteritis as it came to be, which was a different form of what is otherwise called Takayasu's arteritis. I remember when I was doing my DM, we have a very large case series. At that time, it was up to about 300 patients. And just the descriptive data is enough that this got published in the British Heart Journal at that time in the early 60s from Mumbai. Another one, so this was a very infamous paper now. This was a paper on just 12 children. They had some kind of GI symptoms following a measles vaccination, and the measles vaccination was followed by autism. You may know about Andrew Wakefield, who's now been struck off the GMC register. So he's not even a qualified physician in the UK, because this paper was retracted. Most of this data was made up. The patients didn't exist, the biopsies didn't exist. So irrespective of the fact that this was made up data, it was hugely impactful. He's gone on to make a documentary, and in many parts of the world, the misinformation spread by Dr. Wakefield, or Mr. Wakefield now, has resulted in a measles epidemic coming back. So case series can be extremely powerful. They are narrative stories, and we all like stories. So you can convey your story using a case series, which might be enough. Some more examples. So the point is that you can write a case series in even during your training and finish them off in your training. You don't need 5 years to write up a case series like you would while doing a prospective cohort study or a randomized control trial. So, for example, this was during my fellowship in Ottawa, where we have a large program on peritoneal dialysis, and Dr. Mohan Bayani, who's Atul Senior and from Bombay Hospital, who's now a staff nephrologist in Ottawa. He said, "Hey, we have got a few patients who have got serratia, and no one has really reported on what happens to these patients." So we looked back and we found 9 patients who had serratia peritonitis. I got the presentation, the treatment that was given, how many of them could survive on peritoneal dialysis, and how many of them had to switch from PD to hemodialysis. And that's all we had. And we reported, and it was easy to get that published because there was only one case report prior to this. There was nothing at that time on serratia peritonitis. So 9 patients. This was done during a 1-month posting I had in the home dialysis unit. So these kind of studies are possible. You have to be careful not to overreach what you're doing, and causation kind of conclusions are hard to make. But again, these are still very powerful. This is still widely cited, and it's useful for all the other people who see a patient with serratia, saying, "Hey, oh, no one has reported serratia. How do I do? What happens? How do these patients behave? Do I have to take the PD catheter out?" So this is a useful resource which says that you don't always have to do it. Sometimes it's possible, or at least it worked for us. So what kind of analysis should you be doing if you're doing a case series? Sometimes it's just enough to present the table 1. You need not do any kind of comparisons. You need not have t-tests or anything at all. Just a descriptive analysis of the patients and their outcomes is often enough. And that is the best course of action because you don't really need, just the clinical course and presentation is enough. You don't really need to say, "Hey, this is better than that," because remember, this is a case series. You do not have any comparator. It's extremely optional to identify 2 groups within it. And I'm saying extremely optional because, we did that in our study. We looked at patients who got aminoglycosides versus those who did not. But it's extremely weak quality data, right? You've got 9 patients, 5 received aminoglycosides, 4 of them did not. It's not only a retrospective nature with other confounding aspects there, but the numbers become smaller and smaller. And if at all you do anything, you do just some simple tests like t-test or chi-square. You don't go beyond that in a case series. So moving on, some of the comics that were my favorite were Asterix, apart from the Indrjal comics when I grew up reading. Why am I showing Asterix? Because they beat up the Roman legionnaires all the time. And a Roman legion consists of many soldiers. It consists of cavalry, but also the infantry. And the infantry is a bunch of cohorts. One cohort is 6 centuries, as you can see there, and a century is 80 soldiers. So a cohort is technically 480 soldiers. So that's where the word cohort comes from. We talk about retrospective and prospective cohort studies, and it all comes down from the Roman army. And this is not a picture taken by me. I do like photography, as Atul alluded to, and this is not a picture of Ottawa or of Canada. It is located somewhere else in the world, but I think many of you are familiar with this place. It's in Northeast England in the state of Massachusetts, and it's a few hours away from Boston. It's a place called Framingham. So Framingham is perhaps the most famous cohort study ever. So, I'm sure many of you have calculated the Framingham risk score. There are papers in New England or JAMA almost every other month from the Framingham cohort. It was started many decades ago by a few very, very smart and visionary people. And they have collected data on this, on a large group of people in Framingham, sequentially with health outcomes collected over the years as well. That cohort study has given us some of the most powerful and useful data we have because it's a high quality data collected prospectively. I think there should be more prospective cohort studies done all over the world, possibly even in India. It takes some effort to set up a prospective cohort study, but the effort is worth it. And if some of you are able to get together and start a prospective cohort study, it may take a long time for the fruits of that cohort study to come back. So you may be able to start a cohort study, and the fruits of that cohort study may not come to you. It may be coming to someone else in the future. But it's still worthwhile. The next generations will be benefiting from the work that you are doing. So this is how one usually thinks about cohort study. So if you are doing a retrospective cohort study, you begin at one end and you start now and you go back in time. Whereas a prospective study goes forward in time. So you begin, let's say, in 2020 and you start collecting data. It may take 2 or 3 years for you to have enough sample size to even look at the data. So if you're in training, starting a prospective study will not get you the data enough by the time you give your DM or DNB exam. It's still nevertheless useful for someone else in the future. And there's something else. So there are cross-sectional studies, and they are just a snapshot in time, where it's like getting a point prevalence. So today on August 8, 2020, you look at a bunch of patients, or you look at your database and see what is going on. And all these studies have some advantages and some disadvantages, as we can discuss. So a cross-sectional study, it has a few advantages. So it is fast, it is relatively cheap, because you don't have to follow patients up. You don't have to go back in time, and you don't have to go forward in time to see what is going on to them. But it's often useful to give a point prevalence of a disease, right? So what is the prevalence of hypertension right now in India? You do a large survey and you get a point prevalence. And it's useful for chronic diseases with the low fatality, which is important, because if it's a disease where people die very soon, they may have already died yesterday. And if today you look at how many patients have this disease, you may not find many of them. And it will give you a false sense of what is the actual prevalence. And they do not provide a natural history, right? Because you do not know how many of the patients with hypertension that you're seeing today, when did that hypertension begin? What is going to happen in the future? How many of them are going to have heart failure? How many of them are going to have kidney failure? How many of them are not going to have heart failure or kidney failure? That sort of thing cannot be studied using a cross-sectional design. So you have no way of establishing any cause and effect as well. How should you treat the hypertension? Do patients whose blood pressure are higher or lower have better or worse outcomes? A cross-sectional study cannot help you there. And it's hugely biased by loss to follow-up or death. So patients with high blood pressure who stopped coming to your OPD and are no longer in your database. Patients with severely uncontrolled hypertension who died of a stroke, and hence they are not coming to the OPD today. They are no longer in your database. You will be missing all those kind of patients. So those are some of the weaknesses of a cross-sectional design. And this just shows that in a different format. So each line represents a patient over time, starting from one end to the other end, from the left to the right. So that's over a period of time you have a patient, and by a circle I'm denoting someone who's either died or is lost to follow up. And the arrow denotes that they're still alive and they're still being followed up. Now, if you look at a point in time here, you may have 1, 2, 3, 4, 5, 6 patients, but you will be missing 3 patients there because they haven't yet started coming to your OPD. And you will miss the fact that 2 of the patients that you're seeing are going to soon die in the next few days. On the other hand, if you go to this space in time, one of the patient doesn't have enough follow-up. Maybe they are lost to follow-up. 2 of the patients have died. So you have got 4 patients, but you are missing the fact that 2 of the patients who had the condition that you are describing have already died. You're missing those patients. And if you go here, yes, you do have a larger sample size. You've got 6 patients, but again, you're missing the 3 patients who have, 1 patient lost to follow-up and 2 patients who died. So again, you can mislead yourself by doing a cross-sectional study. And if you're trying to describe the natural history of a disease either, or you're trying to describe any kind of cause and effect relationship. So as an example, for again, I'm trying to show that these studies are relatively easy to do. This was another study done during my fellowship, near the tail end of my fellowship. So we looked at, we have about, at that time we had about 700 hemodialysis patients in our unit, and we gathered the data on all of them. As some people may know, we have a large use of central venous catheter and perm cats in Canada. Roughly 50% of our patients have central venous catheters, which is what we reported in this study. And we tried to look at what are the factors associated with central venous catheter use. Now, one of the results that we reported here is that as the patients are on dialysis longer, so the patients who are on dialysis for more than 5 years, and especially those who were more on dialysis for more than 10 years, 75% of them had a fistula, and only 25% of them had a line. Whereas if I look at the patient who were on dialysis for less than 1 year, it was the other way around. So 75% of them had a central venous catheter. And how do you explain that? There are many different explanations that you can give, and the cross-sectional study design doesn't let you allow to make any kind of firm conclusions there. But for example, it is just possible that patients who have a central venous catheter are usually sicker and they are more likely to die. So, in the 10-year follow-up, I have only got the patients who are, cherry-picked. They are healthier than the other patients. And that's why they are the ones who have a higher proportion of fistula. It's possible that, a bunch of patients got transplanted. Some of them died. So all those things are missed if I'm trying to describe any kind of relationship in a cross-sectional study design. And you can also have exactly wrong conclusions here. So this was it's a cartoon from XKCD, and you may have heard about whether cell phones cause cancer. And there are many of these graphs where they show, hey, that cancer goes up, cell phone users have gone up, and this is just a joke on the thinking here that you cannot determine causation from this. And what this gentleman is saying is that, he thinks cancer causes cell phones because, the increase in cancer actually preceded the increase in cell phone use. And it's a completely ridiculous outcome because we know there is no way that cancer can cause cell phones. But this is where, if you're not understanding the biology and just looking at numbers and crunching numbers in a software, that you can go quite wrong. So moving on to, we talked about case series design. We talked about cross-sectional study very briefly. Let's talk about some other study designs. So a retrospective study. So in a retrospective study, you start today. That's the blue box. And then you have, in your database, you have some patients. So you may have patients who are on dialysis, and you may have patients who are not on dialysis, just as an example. And then so you have got 2 groups of patients for which you know the outcomes. And then you try to go back and identify some risk factor and see, how many of the patients who are on dialysis had that risk factor, and how many of the patients who did not have dialysis have that risk factor. So the risk factor is, let's say in this case, it could be hypertension or uncontrolled blood pressure. So those would be the exposed, and those who had better blood pressure would be not exposed. And you try to develop a relationship for that. On the other hand, a case control study is quite different. So in case control study, you've got cases. So let's say you've got 50 patients who are on dialysis, and then you choose controls. So, you've got 1,000 patients in your database. Out of that, you choose, either 50 or 100 patients who are not on dialysis. And then you try to look at the blood pressure control in all of them, in these cases and controls going backwards. to decide if blood pressure causes kidney failure, to take a random example. So in this case, in a case control study, you have a small number of cases and you're selecting a bunch of controls from the wider population. And this is where things get tricky very, very fast. I'm not advertising Netflix here, but you may have seen this series on Indian matchmaking, talking about an arranged marriage, I think, in India, which has become very popular here as well. What does that have to do with case control studies? It's all about matching. It's all about finding the right match. And if you don't find the right match in your case control study, your study will be hopelessly flawed. It will be hopelessly biased. So be extremely careful while doing a case control study if you don't know how to find the right controls. So how do you match? How do you find the controls? You don't want to overmatch, you don't want to undermatch. And how do you decide that? So in general, the principle, so if you look at the epidemiology textbook, they will say that for a case control study, the comparison group, that is the controls, should be representative of the source population that produced the cases. So let's say you have patients who are on dialysis, then you don't choose controls from healthy volunteers. You don't take you don't go to the medical college and choose some medical students as controls. That is completely unhelpful. They are dramatically different than these cases. So it's not really going to be useful for you to choose controls that way. So the controls must be sampled in a way that is independent of the exposure. So the exposure, and it depends on what is the exposure. Is it going to be blood pressure? Is it going to be some genetic makeup? Is it going to be, say, smoking status or what have you? So the selection of the controls must be independent of the exposure. So it doesn't mean that, let's say it's blood pressure. You do not go to the hypertension clinic if there is a hypertension clinic there and choose patients with resistant hypertension there. You do not go to an infectious disease clinic there because none of those patients will have high blood pressure at all. So you have to choose patients where the exposure is not likely to be very high or very low either. So I'm sure this is going to get confusing for you, the way the theory describes. But this leads, the way the controls are selected can very easily lead to selection bias. So you may think that you're doing a wonderful study, but the data you will come out will be horribly biased, and no analysis can help you. The other thing is you're going back in time, right? So you've got cases today, and you're going to say, 5 years ago, where you, I don't know, did you travel to Delhi 5 years ago because there was a lot of pollution in Delhi? And we are trying to see if the exposure to pollution in the cities caused kidney failure. Now, it's the person you're asking today will have to think, okay, where was I in 2015 and what did I do in 2015? Or it could be, are you taking painkillers? Do you take ibuprofen or diclofenac or what have you? So they will have to think, have you taken that in the past? There's an element of trying to remember what happened 5 years ago or 6 years ago or 2 years ago even. Right now, I don't remember what I had for breakfast yesterday. So it's not always easy especially when you have a chronic illness, to remember things. And the other aspect is that cases may remember things very differently than controls, which leads to information bias. So how is the exposure information collected? You have to ask them about it. So the example that Dr. Datta gave was about eating eggs. So do you eat eggs day to day? Or if you're looking at some bad outcomes that happened after pregnancy, did you take any painkillers during the pregnancy? Now, what is likely to happen is that if I'm a patient and I've had a bad outcome in my pregnancy, then I'm going to try to find something to blame. So it's very likely I will remember that one time that I took ibuprofen in the second trimester. Whereas, if I'm a patient who had a normal pregnancy, and even if I took a few ibuprofen, I'm likely to forget. And I'm quite likely, it's just human, that I'm not likely to remember something because everything worked out well. So that leads to a recall bias, which is kind of a information bias. So cases are more likely to remember something to blame, which can be blamed for them having whatever disease they have. And controls are less likely to remember bad things. They are more likely to remember good things, right? So it can be biased in either ways, and they can say, hey, yeah, everything worked out well, because I had this supplement. And cases may say, oh, I forgot to take the supplement one day, and that's why I forgot to take folic acid, that's why this thing happened. So the recall bias is huge unless you can capture the exposure in a very, very objective way. A case control study is hopelessly biased again. So as an example, I hope there is no one from ICMR listening to this talk. This was, Divya Bajpai from Mumbai highlighted this study on Twitter. They did a study on healthcare workers and COVID, and they did a case control investigation, which is, I find that completely bizarre that someone would do a case control study when they had this kind of a database. So let's see what they did. So they took healthcare workers. As you remember, all healthcare workers were given a directive to start taking hydroxychloroquine. So they took the healthcare workers who were tested between the first week of April and for a month, so until the end of the first week of May. And that formed the sample pool from which cases and controls were drawn. Now, instead of using the whole sample size, they decided to take a few cases and a few controls. And I'm not sure why they decided to do that. So then they made what they call a brief 20-item interview schedule. And as you can see, it wasn't really that brief. It may have been brief from the point of view of the investigators, but from these healthcare workers, right? You imagine you're a nurse or a doctor. You're coming, you're at work. You've been seeing patients with COVID, wearing that whole PPE. You're coming back home. You've got family. You're worried about whether you're going to infect your family. You have to make food, take care of your family, and in the middle of that, someone is calling you with an interview, a 20-item interview. So they asked information about designation of this, designation of that. What did you do? Did you wear a mask? Did you wear that? And they say, oh, we minimized the recall bias by just restricting it to 7 days before the testing. But it was all collected over the telephone. It's all completely based on the recall. So let's see what they actually collected. So, and this is where it tells you how things can easily go wrong. And they report this. It's very nice that they report all these so you can make up your mind for yourself. They wanted to have 650 cases and controls, but they could not even contact 650 cases and controls. They had 624 and 549 in cases and controls. And even in those groups, they could only complete interviews in about 60 to 70% of them. So firstly, they could not reach those 620, 650 because sometimes the numbers were wrong. Sometimes people did not pick up, or someone else picked up the phone, or they refused. So you don't stop if your sample size is 650 and you're not able to contact 650. You keep going on until you get 650. So that's not quite clear why they decided to stop. But of the data they got, they could only use 60% of the data, which just tells you that you're asking someone on the phone, people are going to say, I don't remember. Or if you don't remember, are you going to make up something and tell them? And again, try to think, if you got COVID or if you did not get COVID, how likely is that going to change your answer? Not deliberately, is that just going to play tricks on your memory? So that aspect is going to what that means is that the number of people who are in your cases and controls itself is different. For example, the missing information. It's possible that some of the cases did not pick up the phone because they got COVID and they died. How do you know that? And it's possible that some of the controls also same thing had happened. How sensitive are these tests? And people may have got, the testing was done at one period of time, but they may have not had COVID then. They may have developed COVID afterwards, and something bad may have happened. So there are many flaws here, just in the selection of and labeling people as cases and controls. But then you look at the table one. typically, some of the findings are not surprising. I'm a man, and they do report that men have more cases. They had more likely to have COVID than controls did. Younger people seem to have a little bit less, though they don't find that significant because they are testing 10 groups. But I can easily see that there is some differences there which are significant. And among the older, there was more likely to be cases than controls. Whether people were doctors or nurses, housekeeping staff, all those things, though the p-values are not significant, the numbers look different to me. The duration of workplace was usually different. And again, all this is from history. So, remember, you're being asked all these questions. How old are you? Are you a doctor? Are you a security guard? How long have you been working in your workplace? While, some evening you're at home, you're answering all these questions. But it doesn't stop here. Let's keep going on. They ask these questions. Did you work in an ICU? Have you done NP swab collection? Did you do endotracheal intubation? Did you do suctioning? Did you handle clinical specimens? Did you ever use a PPE? How did you use it? Did you forget to use it sometimes? Did you use it all the time? Did you put a mask on? Did you put a cap on? Did you wear a gown? How many times did you wear a gown? And if you put yourself in one of the shoes of a person answering this question and try to remember, all of you, I'm sure, have taken care of patients in the last few months, is that would you be able to give very clear answers for all these questions if you're suddenly called and asked? Gloves, face shields, it keeps going on. And then it talks about whether you took hydroxychloroquine. If you took it, how many doses did you take? And again, it's being asked, a month ago they're calling in June, asking about what happened in April and May. And did you take hydroxychloroquine on 5th of April? I'm not sure I would be able to remember what I did on the 5th of April. And how many doses of hydroxychloroquine did you take? Did you take it with this? Did you take it with that? So again, remember what I said is that cases are more likely to remember something to blame if they got COVID in this case. And controls are, less likely to remember. Controls will think, oh yeah, I did, I was perfect in putting on the PPE, and I took hydroxychloroquine every day. Whereas cases are more likely to say, why did I get COVID? Maybe, that day I did not wear the mask properly. Or I was reusing the mask and it wasn't fitting properly. Maybe that is to blame. So you're more likely to find things to blame if you have got the case. So there is that. And then they find this very, very odd result, where if you look at hydroxychloroquine, if you take it, there doesn't seem to be any difference. But if you take 2 to 3 doses, you're more likely to get COVID. But if you take more than 4 or 5 doses, you're less likely to get COVID. So, the graph goes like, hey, if you took any hydroxychloroquine, you're not at higher risk. But if you took 2 or 3 doses, you're at way higher risk than if you took, less than that. So there is no biological gradient there as well. So there is selection bias, there is recall bias, and there is a very strange biological gradient. I'll come back to this case crossover design. But if you believe this, the ICMR case control study results, I will come to you and sell you something because, and maybe you are the sort of person who believes when you get an email saying, I'm a prince from Nigeria and I have a huge treasure that I can share with you. So we are about just over half an hour into the talk, and rather than me talking, I wonder if people have any questions, and I would be happy to stop here and answer some questions before we go on. If Atul or Aniket would like to do that, or let me know if I could just go on.
I think Priyambada would like to do the questions. Yeah. Priyambada, please go ahead.
Yeah. So, there has been a couple of questions. The first question is from Dr. Rajiv Sinha. Does a large case series become cohort study? Does cohort studies need to be prospective?
Yeah, so what is a cohort study? Is it just a large case series? That's a good question. A case series, there is no number limit at which you can say the case series is a cohort. Case series are usually just one topic. In this case, for example, let me talk about serratia peritonitis. So, I had 9 cases of serratia peritonitis. On the other hand, in a cohort study, it's not just one disease and one exposure that you're talking about. Let's say in my database, I have got 400 patients with peritoneal dialysis and peritonitis. And I look at, how many of them had serratia, how many of them had Staphylococcus aureus, and how many of them had E. coli peritonitis. Then that's more like a cohort study. And in the cohort study, you've got, longitudinal follow-up, you've got multiple exposures, you've got multiple covariates that you are available for yourself that you can look at. A cohort study is powerful because, it's a large set of, the 480 number I gave was just made up. But you've got a large number of patients with many different outcomes, with many different exposures or covariates that you can examine. And you can answer multiple questions from a cohort study. A cohort study can be retrospective or can be prospective. I'll come to retrospective cohort studies in the next section, but a prospective cohort study, if you decide to start collecting data today, it will take many years for you before it's available for you, and it's still worth doing. I'm not saying it's not worth doing because they give you really clean data. In a prospective cohort study, the patients who are lost to follow up, and the patients who have died very clearly. In a retrospective study, you're going to miss a lot of those things. Those are, I hope I answered that question.
Next question is from Venkat. In a prospective cohort study, as you are recruiting subjects at various points of time till one reaches adequate sample size, how do you avoid lead time bias creeping in amongst those who were recruited earlier?
Yeah, so lead time bias is slightly different than the time of recruitment. In a prospective cohort study, you're not necessarily pitching for a sample size of 100 or 200 or anything like that. You collect in a prospective cohort study, you collect as many as you can. The larger the sample size, the better it's going to be. It's not like a randomized control trial where you have 500 patients and the study is powered to answer one question using those 500 patients. And let's say you have patients recruited on the 1st of January and the 6th of January and the 20th of January and the 6th of August and so on and so forth. That is their starting point in your cohort study. Lead time bias refers to something else. Lead time bias is talking about the time the diagnosis was made and the time the exposure started and time the outcome is collected. It's a slightly different concept than just the length of follow-up and when the patients were included in your study.
The next question is from Dr. Anita. Is there a time frame for completion of cross-sectional study? Like it should be collected, the data should be collected in a month or so?
Yeah, so ideally it is, again, it's a cross-section, right? So it is in one point in time. And it depends on what is your disease that you're looking at. If it is hypertension and you're collecting it over a month, it's fine because it's a chronic disease and it doesn't matter much. Whereas if you're collecting on, say, COVID and you do it over a month and you say that, hey, this is what is going on. Well, from 1st of January to the 30th of January, some of the patients that you collected data on the 1st of January have already died by 30th of January. And some of the patients that you collected data on 30th of January did not have COVID on the 1st of January. So that is going to be extremely misleading for a disease that is acute, in which the outcomes are done very fast. So again, the answer is, in most cases, the answer is that it depends. And you have to look at what you know about the natural course of the disease when you're doing a cross-sectional study. We did, for example, a few years ago, the International Society of Nephrology was doing this 0/25, where they were trying to get, the aim being AKI should go to 0 by 2025, which is a very ambitious goal. But at that time, a bunch of us were involved, and we said, hey, we were given one date. So on that one date, let's say 15th of March, we collected the number of patients of AKI that we saw. And many people all over the world, but it was planned that you will look at that one particular date and you will say, hey, on this day, I saw 6 patients with acute kidney injury. And these were the causes of that acute kidney injury. So that gives you a snapshot of, how many patients with AKI are seen on that one day globally. And it can be done, but you have to plan it that way, and you need a large team to do it that way.
The next question is from Sri Durga. What is the difference between case series and cross-sectional study?
So cross-section is just one snapshot in time. And in a cross-sectional study, you will have, let's say, you're looking at the 500 patients who are following up in your clinic, as we did. Some of them have a catheter, some of them have a fistula, and we are looking at all of them. In a case series, I'm looking at only one particular condition. So, I'm looking at, let's say I'm looking at patients who had, so we published a case series a few years ago on patients who had a perm cath, which was kind of stuck or embedded, and we could not remove it out. So we had 11 such patients. And we reported just on those 11 patients who had a stuck perm cath and how we removed that. And so that's a case series because I'm looking at one exposure and one outcome in those patients. Whereas, if it was a cross-sectional study, I would have said, hey, I had 500 patients. Out of them, 11 had this stuck perm cath, and this is how those 11 patients were different from those 500 patients. A case series is more like, all of them have the same disease. There is nothing else going on. And you're describing that one disease or that one condition, which is kind of different than what everyone else knows about that condition.
There's another question from Sudhir Ranjan Dash. Can cases be their own controls in any of the trials?
Yeah, so that's a very good question. So let me go, if you can see the slide, there is something called as a case crossover design. This is where, so there is in prospective randomized control trials, you may have heard about a crossover design where patients get, one drug and then they get another drug subsequently. And there's a period of washout in between. But this is not a prospective control study. This is a case crossover design. So in a case crossover, what happens is you're looking at something that is acutely happening. So for example, and you compare this to the same person at some different control period of time. So the pollution is an interesting example. Let's say the pollution in Mumbai changes over a period of time. And we know that, in the month of, on 16th of June, it was extremely, it was very foggy and there was a lot of smoke and particles in the air. And so the similar thing happened on 28th of July. And so you take those 2 periods and then you take 2 other control periods when there was nothing like that, when the air was very clean. And then you find out, you take a patient who had some kind of health event and you see if they had a health event during the, let's say COPD, asthma exacerbation. And you say, hey, was there asthma exacerbation on the 15th of June compared to, the 4th of March when the air was clean? And if they had an asthma exacerbation at both period of time, that would suggest that the pollution is not playing a part. But if you see that, that day when there was pollution, this person did have an acute attack of asthma, but on the day there was no pollution, there was no asthma attack. Now, these are very tricky to analyze. In some ways, they're powerful because the same patient serves as a control for themselves. So your sort of the case is, the control is just the time period, which is different for them. So the analysis is a little bit tricky, and it's because the exposure is changing over a period of time and you're taking advantage of that. There are very, very specific circumstances in which you can do a design like that. And I would talk to someone before jumping into that kind of a study design.
There are another 5-6 questions. Are we going ahead with the questions, or would you?
Sure.
Like
Let's go ahead with maybe let's go ahead with the presentation and we can come back to the questions.
Yeah.
Thank you.
Okay.
So just to going ahead, just to summarize case control studies before going on to cohort studies, it's good for rare diseases to determine associations. So if your disease is not rare, so, for example, COVID is not rare right now. So to choose a case control design is completely inappropriate. And selection of the proper controls is extremely crucial. More importantly, there's a high risk of selection bias and recall bias. So be very, very careful if you're doing a control study. They look like they're easy to do, but they are at a very high risk of bias. You may get them published, doesn't mean that they're advancing the science. So let's go to a retrospective study. So just to recap, you start today, you've got some patients who have an outcome and some patients who do not have an outcome. And then you go back and look at, what was the exposure status in those who had the outcome and those who did not have the outcome. But just to put it in English a little bit, before you go on to that, you have to identify the question very clearly. You have to look at the feasibility of whatever database you have in answering that question, and you go through a chart review process, and then you analyze it. So for example, I'm taking a random example. We know that fish oil doesn't work, but let's say you do think it works and you're trying to look at fish oil and the risk of developing end-stage kidney disease and IgA nephropathy. So you know that you've got fish oil intake. Some patients take fish oil, some patients don't. Some patients have got end-stage kidney disease, and some patients don't. So the exposure is the fish oil intake or not, and the outcome is some patients got end-stage kidney disease, and some patients, they do have IgA nephropathy, but they have still not ended up on dialysis. So they have, slower progression or non-progressive kidney disease. So how would you get that, right? So you look at all the patients in the ROPD, and you take the patients who are on dialysis and say, hey, this is my pool of patients. So let me ask and find out how many of the patients with end-stage kidney disease were prescribed fish oil in the past. If you've got, records, that's fantastic. And we'll find out which one of them did not take a fish oil. And you go back in time to do that, to find out their exposure status. Now, this is where the first flaw can happen, is that some patients may have died in between, and they may have stopped coming to your OPD. And it depends what were they doing. And some patients may have been lost to follow-up. They stopped coming for whatever reason. So just to take an example, let's say if fish oil actually caused more death, then all those patients will disappear, and they will not be alive to live on, to go on dialysis. And it may appear that, hey, there is less end-stage kidney disease in the patients with fish oil because the people who died have disappeared from your database, and it will appear to be protective. What about if patients who were given fish oil, they didn't like the taste, and they said, hey, this doctor is giving me medicines which that don't taste good. So they stop coming to see you. They go to some other hospital. So they will disappear from their database, and that will give you a biased result as well. And this can bias the result in different ways depending on what the effect of the fish oil is going to be. So the loss to follow up can be random, or it can be non-random. So if patients who are given fish oil and those who are not given fish oil are both going to be lost to follow up, then it matters less. It may just bias your results towards the null. It is a kind of information bias, but it will just bias your result towards finding no effect, which is bad, but it is still it's less bad perhaps. But if it is non-random, that is if patients who are taking fish oil are more likely to be lost to follow up, then it's going to bias your results away from the null, and you're likely to see an effect which is not there. So you have to think about that a little bit while looking at it. Is that, do you think, and it's, if you're doing a retrospective study, you may not be able to determine if your loss to follow up is random or non-random. But if you are able to determine it, and you see that, you had in 2010, you had 500 patients on fish oil, and today, you've got only 300, and you don't know what happened to the other 200. Whereas in the non-fish oil group, you had 500 patients and you have outcome data on all 500. That tells you something strange is going on, and that your results are not going to be reliable. And this is in general, as with any rule, there are exceptions to the rule. So there are other problems, right? So again, let's say Dr. Hiremat, I believe in giving fish oil to everybody. And Dr. Mule does not believe in fish oil. He has stayed up to date with the literature, and he knows fish oil doesn't work. So he doesn't give it to everyone. But both of us work together. All our patients are in this database, and you are collecting it. You don't really know that factor that, that Atul gives fish oil to no one, and I give fish oil to everyone. But there may be different things in how we practice, which may impact the outcome. For example, Atul is a very conscientious doctor. He gives every patient, an ACE inhibitor or an ARV. He makes sure that blood pressure is really well controlled, and he doesn't give fish oil to everyone. And Swapnil Hiremat is very busy. He spends more time on Twitter and taking pictures. And his patient's blood pressure is, sometimes it's not well controlled. He doesn't really find out whether they're taking their pills or not, but he gives everybody a fish oil prescription. So then it may look like maybe fish oil is worse, just because Atul's patients do better than my patient. But if you don't know that this is going on, it's going to bias your result. So there are many other factors that could be determining the fish oil intake that may be associated with outcomes. So this is what is which can bias the results. So selection bias is referring to things that you cannot even measure. So it's possible that, there are some patients who are educated, who go on the internet, they find out that fish oil may be beneficial for IgA nephropathy, and they start taking fish oil. But they may be doing a lot of other things that you don't know, right? They are more educated. Maybe they are taking their pills properly. They have got better access to care. They have money to take their pills on time. And maybe that is why their outcome are better. And you may think that fish oil works in reducing the risk of kidney failure, when actually it doesn't. It's picking something else up. That could be confounding. Maybe some people take fish oil more than don't. The example of, Atul's patients are not taking fish oil, mine are. And there are other factors related to us that could be playing a role. But these are things that can be measured. So confounding is something that can be fixed. And information bias, right? So, patients who died or were lost to follow up. And if it's an informative loss, then that would bias your results. So in the analysis, you could either report an odds ratio or a difference in means, and you would put in the covariates all the other things that you think are important. Typically, we include age and gender. For a question of IgA and fish oil, for example, you would put in blood pressure control, baseline creatinine, proteinuria, and many other things, right? Diabetes. And odds ratio are simple to calculate. 20 people took fish oil, out of the 100 people who took fish oil, 20 got ESKD. Among those who did not take, 40 got ESKD, and your odds ratio would be just a cross product, so it would show a huge protection. And again, this is made up data. I don't think fish oil works. Or you could report a difference in means. If you got change in serum creatinine, you just do a t-test, and these are SI units, so they're slightly different than the ones you use. But the t-test can show that the creatinine is lower in those who have fish oil. So all sorts of things are possible. So table 1 is really important, and how do you select your covariates is very important. You have to look at table 1 very carefully, which is describing those who took fish oil and those who did not take fish oil in this case. And so table 1 in a cohort study should describe the exposure, should be divided on the basis of exposure. Table 1 in a case control study would be divided in terms of who has the disease and who does not have the disease. So if you're doing a case control study of those who got COVID versus those who did not get COVID, your table 1 should have a column for COVID and a column for no COVID. In a cohort study where you're looking at fish oil and no fish oil and who got end-stage kidney disease, your table 1 should have a column for the exposure, which in this case is who got fish oil and who did not get fish oil. And this should not be on the basis of outcomes, because you're looking at the relationship from the exposure point of view. And to adjust for confounding, you can either do stratified analysis or you can do some regression. So what is confounding before we go there? And again, I think Dr. Saurabh Datta had talked about it last time, and perhaps it was covered earlier as well. But let's say you have a lighter in your pocket and people develop lung cancer. That's really, you may think that having a lighter causes lung cancer. This is a ridiculous example, but it just tells you that the lighter is confounded by the fact that smokers are more likely to carry a lighter in their pocket. And it's the smoking that is causing the lung cancer, right? We know that now. And the lighter has really no relationship with lung cancer. And what you're trying to find out is what is this factor, which may explain the relationship between the exposure and the outcome. So for example, alcohol, I'm taking, there are, you have a large data set, and it looks like less of the patients who are drinking have heart disease. So alcohol is protective against heart disease. But if you actually look at a age stratified analysis, what you may see is that among the patients whose age is 40 to 64, the relative risk actually is 1. It's no longer, 0.3. And if you look at the patients who are older, again, the relative risk is 1. So what is happening is that you have a slightly skewed age distribution in your cohort. And once you take age into account, there is no relationship between alcohol and heart disease. The other way to look about it is, what is the risk of heart disease in older versus younger? So in this case, among the older people who are drinking alcohol, the relative risk of dying is 10. And among the younger people, among those who do not drink alcohol, the risk of dying if you're older compared to your younger is 10. So what we are really seeing in the in this example is that you thought that alcohol is protective, but really because your sample is enriched with a more slightly skewed age distribution, it makes you think that there is a relationship between alcohol and cardiovascular disease, which is really driven by age more than by alcohol. So unless you know that age is a factor, and age is always a factor, it's almost always a factor, then you would get a confounded result. So for an adjusted analysis, you have to try to pre-specify the covariates you indicate. For example, age, sex, baseline creatinine, CKD, diabetes, blood pressure are pretty common. And there are some rough rules of thumb is if you've got 10 events or 20 events, then you can have one covariate. If you talk to a statistician, they will say there is really no basis for that rule. And you look at the table 1 and you look at p-values, and sometimes you let the data drive the selection of covariates, and you do a backward or stepwise regression. But again, if you talk to a statistician, they will say this is really, this is data driving you to results, and it's going to give you biased results. So be really, really careful if you're doing this, and perhaps don't do it. And just because you've got a software package doesn't mean you should play around with it. And just to take an example, even if you've got a large database and registry, remember that they have data collected for billing and administrative purposes and not for research. And that can lead you astray. So the large number can give you a higher precision, and you can do some propensity score matched analysis, for example, but there's a high risk of bias. You need to have someone who's familiar with the database. And there's a nice story that I'll link to which talks about that. For example, we did this. So there is a large database in Canada which has all sorts of drug data as well as outcomes. And we looked at alpha blocker usage and reported that in older women, alpha blocker usage leads to more, hospitalized hypotension, fractures, and falls. And we had started with, if you see, we had like 7 lakh 40,000 patients or so, and we did propensity score matching to end with about 28,000 patients. So that's the advantage, because the sample size is so huge. You can select patients by propensity score matching who are kind of very similar to each other otherwise, apart from the outcomes. And what that does is, for example, here, those who were given alpha blockers had way higher risk of diabetes, had way higher prevalence of diabetes than those who did not. But after propensity score matching, we can take those differences out. So then diabetes no longer is a confounder by doing propensity score matching. But you need really large sample sizes in your database to do that. On the other hand, it can lead you astray. So this was a paper in JAMA that was retracted, which reported on the association between dialysis facility ownership and access to transplant. And this is the original paper, and which reported a hazard ratio of 0.36. So those patients who were dialyzed in a for-profit center had less likelihood of getting a transplant, so 60%, 64% less. But what was actually happening was, after they found a coding error, it was actually 0.8. So maybe, 15, 20% lower with residual confounding, and there's almost no effect. And why did that happen? So this is a story that, this is a nice podcast which goes over what happened is, the way the databases were merged led to this thing. I would encourage you to read it, and it's kind of a warning that if you're playing around with a large database, make sure you you know what you're doing and have someone who is skilled in using that database. It's possible to do, simple continuing quality improvement studies where you take a problem, a real clinical problem, you study what is happening, you decide to implement a change. And something that is very easy to do in dialysis is, looking at infection rates. For example, we do this periodically is we track the number of patients who have bloodstream infections. And if we see something going on, we see some kind of a trend, then we'll say, hey, we'll examine what is happening there and we'll implement some change. And then you will try to do something to fix it. And I'll just briefly touch upon systematic reviews is, for example, you can do a systematic review of fish oil in IgA nephropathy. You need to have objective search criteria. You search in databases, and there is going to be an advanced methods workshop later on this year, which will go into that. And you need to have pre-specified inclusion-exclusion criteria. You may do a systematic review with or without a meta-analysis. And a systematic review, these were done. This one was with Atul when I was still a fellow. Doing my fellowship before completing my nephrology fellowship. So these things are possible to be done during your training, and they don't take as long. And this was, one of our medicine residents when he was doing nephrology. Remember, though, that a systematic review of randomized controlled trials itself is an observational studies, and it can have selection bias. For example, studies do not get always published. That is called publication bias. They can have the same confounding that I talked about, which can be explored by doing a meta-regression, and that can be information bias as well. So even though you're including trials, your meta-analysis is still an observational study, which seems kind of a paradox, but it's just something to keep in mind. This is just a picture of Ottawa. This is the Parliament Hill in our capital city. And in May, we have a nice tulip festival. If you want to explore, we do offer a clinical fellowship with a decent salary and a nice exposure to life in Canada as well as nephrology. So think of applying if you want to come here for a fellowship. I had a few slides on how to read a paper, but I think there's going to be a critical appraisal workshop. Are there a lot of questions, Priyamvada, or should I keep going on?
Hold on for a second. There are around maybe 8 or 10 questions.
Okay, so let me just skip to some do's and don'ts, and then we can go over the questions.
Can I interrupt for a second?
Sure.
Aniket,
yeah.
Aniket's mic is on. Aniket, can you mute yourself? There's a lot of background interference coming.
Okay, so always try to, and I know some of this was covered by Dr. Datta earlier today, but I would say you should always involve a statistician or an epidemiologist when you're planning the study. If you're already collected the data and then you go to a statistician, they are going to, put their face in their hands and say, this is really not useful. You need to do a lot of other stuff. So either you may get a biased result, or you will have to do a lot of work collecting the data that you really needed to collect in the first place. So try to involve a statistician or an epidemiologist while you're actually planning the study, rather than go to them after everything is done. And when it comes to ethics and funding, even if you're doing a case report, nowadays journals want a consent from the patient. And if you're doing a case series, because it's a bunch of patients and you cannot identify one patient, you don't need consent, but you do need ethics permission from your institute to report on those patients. If you're doing a retrospective cohort study, you do need ethics permission, and sometimes depending on the resources you may need some money as well. If you're doing a quality improvement study, you may or may not need ethics approval. So it's a little bit tricky, and you should consult local guidance. And you may need funding depending on what you plan to implement. In a prospective cohort study, you do need consent of every patient who's included. You need to have ethics permission, and you do need a lot of money because you're going to prospectively follow these patients, and you need someone to call the patient, see them, and find out what is going on. A meta-analysis, on the other hand, needs nothing. You're not collecting patient level data, you're collecting study level data. And that's one reason why I love doing meta-analysis. Now with big data, it sounds very exciting, but sometimes the big data is not in a computer. It may be, you going through a lot of charts, and there is you can easily run into problems. So this is called, one of the biases is finding the pony bias, that Dr. David Sackett used to describe. Is sometimes, you will have a lot of data and you look at it, and sometimes it's forgive my language, but you may have a pile of horse shit, and the correct thing to do is to look at it and walk away. But there are some researchers who look at this and say, hey, if there is a pile of horse shit, that means there was a pony some time ago here, so let's go and find the pony. And with big data, that is something that you may often end up doing, is you may try to get diamonds from your garbage, and don't do that. It's going to lead you astray. A large study can in fact give you more precision, but that doesn't mean it's going to be more accurate. Because of the large sample size, your odds ratio, your 95% confidence intervals will appear very narrow. It doesn't mean that your results are necessarily true. And I would say that simple case series are undervalued. Just descriptive stuff is quite useful, especially if you have got something that no one else has talked about before or reported before. If you do want to do a case control study, go back to what I talked about, the case control study. If you publish it, I'll come back and I'll critically appraise and make fun of your study on Twitter. So consider doing it as a case series instead. There are very, very few examples where a case control study is the appropriate study design. And if you do a case control study, make sure you choose your controls properly. It's very easy to go wrong. It's very, very hard to go right when you're doing a case control study. And lastly, remember that randomized control trials are possible. People think that randomized control trials are difficult, they're impossible, but that is not true. There are a couple of simple examples I put out there. One of the, the START AKI study came out recently, a couple of weeks ago, and I think Atul and Valentine are going to discuss that later on in the course. But Tukaram Jamale and Vaibhav Keskar and others from Dr. Hasse from KM Hospital did a randomized control trial, a single center trial on early start versus usual start dialysis in patients with community acquired AKI, published in AJKD. It's possible to do these kind of trials. Another example from North India on the efficacy of mycophenolate versus levamisole in frequently relapsing nephrotic syndrome. There are many things that are a huge advantage, so AKI, of course, there is a community acquired AKI incidence is very high, but even all sorts of glomerulonephritis are very high. So many of these studies, which would take many more years in the Western world, can be done way faster if you're doing it at your center. Sometimes even single center studies can have adequate power. I'm not saying, you should do randomized control trials, but for many of these questions, early start versus late start, even, nice, well-done studies, observational studies have given the wrong answer. And a small RCT can give you the right answer more likely than a large observational study. And this is just something I put together. This is not written in stone or anything, but people like to have some kind of, evidence pyramid. But the more important thing is that even if you've got a systematic review, which has surrogate outcomes, so in the middle there, a large high quality randomized control trial is better than a systematic review with surrogate outcomes. A high quality observational study with, say, marginal structured matching or propensity score matching is perhaps similar. It can give you a high quality data compared to a small RCT with surrogate outcomes. But the other thing to keep in mind for outcomes is that clinically relevant outcomes are more important than just a change in blood pressure or a change in hemoglobin A1C. At least for those things we know they are useful surrogate outcomes. There are some outcomes like, phosphate or biomarkers, which, you don't really know what do they really even matter. They are extremely, we have no idea if those outcomes are valid. And outcomes rated by patients, for example, quality of life, itching score or something, are just as important as, mortality outcomes. So that would be way more important than phosphate if you're doing a trial and you're thinking about choosing outcomes. And I like to end with, before we go to questions, is that we have a bunch of resources on COVID that we have put. It's on a blog, on an FGC blog. So we have stuff on transplant, on dialysis, on COVID, and in pediatrics and acute kidney injury. It's all freely available there. And I have to give a plug to all the activities we do on the social media stuff. If any one of you is doing nephrology and wants to write about whatever you're learning, it can be pitched to Renal Fellow Network. NephSim is a very useful resource for going through cases on your own at your own time. There are many blogs like the AJKD blog and Nephron Power, which is run by Kenna Javeri in New Jersey. And of course, there's the Journal Club. And listen to our podcast, which is available on iTunes or Spotify or whatever whichever audio service you use. So I would like to thank the Indian Society of Nephrology, Dr. Rajapurkar, Atul in particular, for inviting me, and all the organizers of the ISN Methods workshop. There are some more slides in there which will be available. I'll give the PDF. I'm happy to share the actual slides. If you want to, take pictures, see the video or tweet or use them in whatever way, it's completely free. If you have questions after this, feel free to email me or tweet at me. I hope all of you have a Twitter account or consider having one. That's the best way to learn. And I think with that, we have maybe a few minutes for some questions.
There's a question from Dr. Anurag Agarwal. What is the difference between case control and a retrospective cohort study?
Yeah, let me... I'm trying to stop. So case control and retrospective cohort study. So in a case control study, just give me 1 second. I'm trying to stop the screen sharing. Okay. So in a case control study, you're not including all the patients that you have who have that you have in your database. Let's say you have got a database of 1,000 patients, and you've got 200 patients who have got kidney failure, and you've got 800 patients who don't have kidney failure. Instead of using all the 1,000 patients, you're choosing to take the 200 patients who have kidney failure, and you match them to 200 patients who do not have kidney failure. So that is a case control study. And why might you do that, right? I would argue that as far as possible, try to include all the 1,000 patients. But sometimes it may be that you have to find out some history for all of those patients. So because you're talking about an exposure and you want to find out, what happened to them 10 years ago. And you have to actually individually go to each of those patients and find out what happened to them 10 years ago. So you may not have the resources to ask it for all the 1,000 patients. So, for your convenience, you choose just all the cases, and then you pick 200 controls and you ask that to those 200 controls. And it's often done for those reasons because it's convenient. But in a cohort study, you would choose all the 800 patients and you would try to find out the exposure for all of those 800 patients. So you're not really sampling the entire population available to you. You're using the entire population that is available to you rather than choosing some patients from that, which should be done in a case control study.
The next question is from Dr. Nisha. She is asking about ambispective cohort study.
Pardon, come again?
She's asking about an ambivalent cohort study. She just wants
ambivalent.
Yeah.
I'm not sure what you mean by an ambivalent cohort study. Are you talking about going forward and backward at the same time? Ambispective, yeah.
Yeah, ambispective.
Going forward and backward at the same time. So it's sort of looking at taking, let's say you're starting today and you want to have um, some data right now, but you also want to go in forward in time. So you have a database with 1,000 patients, so you include that. But in those, you're having the exposure collected backward, right? You're going back and finding out what their exposure was, but then you add patients to that database going forward. So you're actually having more patients going in as well. Um, it's just a different kind of study design. I'm not sure what the advantages specifically would be. It's mixing a bunch of things, and you have to be careful with the analysis again.
There's another question from Dr. Ravindra Prabhu. How do we do a prophylaxis study as we cannot control future exposure?
So you're talking about, let's say, a prophylaxis, meaning you want to give something to prevent. And it has to be a prospective study. And again, if you're, for example, is hydroxychloroquine effective for preventing COVID? It makes more sense to do it as a randomized control trial to get high quality data. If you're doing a prospective study of an intervention, to me, doing it as a randomized control trial is going to give you far richer data than doing any kind of observational study, because the patients who get the intervention versus those who do not get the intervention are going to be different. What you can do, of course, is try to enrich your cohort, your sample, to those who are highly likely, who are at high risk, right? And that was the purpose of giving hydroxychloroquine to healthcare workers, because these healthcare workers are at high risk of getting COVID. If I give hydroxychloroquine to the general population, maybe 1% of them would get COVID, and then I would have very few outcomes to have power. Whereas if I'm choosing healthcare workers, you do know that many of them, sadly so, are likely to get COVID. So that is sort of an enriched sample size. But again, if you're doing a study of an intervention and you're starting today, think about doing a randomized control trial rather than doing an observational study.
There's a question from Krishnan Raju. If we collect data from a registry prospectively, is it considered as a prospective study or a retrospective study?
That's a good question. And some of these things get blurred. For example, let's say there is the USRDS database. So people are entering the data in the USRDS prospectively. Yeah. So every year, I have so many patients who started dialysis. I put the data in there. I put their age and gender and whether they were on hemodialysis or peritoneal dialysis and what have you. So the data is being entered prospectively. But in 2020, I'm looking at the patients who started in 2010. I'm looking now at what happened from going backwards. So though the data is being put prospectively, I'm looking retrospectively at that. And sometimes, so especially with registry studies, the semantics get a little bit tricky. And what some people like to call them is to just call them a follow-up study, or to call them a longitudinal study, rather than go into the retrospective and prospective time frame, because the data is being collected prospectively, but from your perspective, you are looking at it retrospectively. And rather than go into the semantics of that, what you should just describe what you did. You say that the data was entered into this registry prospectively, and on August 8, 2020, we decided to look at this question and examine it, rather than try to say whether it is pinpoint the language.
Divya Bajpai is asking, what is propensity score matching in an observational study?
So propensity score matching is going to be done only in an observational study. And again, this goes back to how do you reduce confounding? So there are many ways to reduce confounding. You can, one of the main advantages by doing a randomized control trial is you eliminate confounding. Whether the patient belongs to Dr. Hiremat or Dr. Mure, their chance of getting fish oil is the same. It's random. The propensity score matching tries to get at that. What is done in the propensity score matching is, I have 1,000 patients and 100 of them got fish oil and 900 of them did not get fish oil. Now I'm trying to get at what sort of patients got fish oil. And to put it very crudely, if it looks like only the young people from Mumbai were getting fish oil and the older people from Pune were not getting fish oil, then it's not right for me to compare the young people in Pune with the old people the young people in Mumbai with the old people in Pune. So in the database, I will choose the young people from Mumbai who got fish oil, and I will choose the young people in Pune or Mumbai or wherever who did not get fish oil. So I'm trying to find the factors that lead to the exposure, in this case fish oil, and try to select similar factors that lead to the lack of exposure and choose those patients. You have to be careful that you do not match on factors that are leading to the outcome necessarily. This is often done by, there are different ways and different methods of doing propensity score matching, but you often end up with a much smaller sample size. But we still think it is powerful because you end up with a cleaner sample where the risk of confounding is lower.
Dr. Sindhura Lakshmi is asking a clinical question. In a case control study, for example, she wants to study the retinal changes in diabetic patients with and without CKD. How should she design the study? Like whether there should be 3 groups like diabetes with CKD, diabetes without CKD, and healthy control, or whether she can completely exclude the healthy control arm.
So let's say you are looking at
retinal changes.
Yeah, I'm looking at the question, the retinal changes in diabetics. And it depends. Now you have to identify what is your exposure in this case and what is the outcome you're studying. You know, what you're describing is the population. So the population is, the diabetics. And if your question is, are CKD patients more likely, CKD patients with diabetes, more likely to have retinal changes than CKD patients without diabetes? Or sorry, are CKD patients and diabetes more likely to have retinal changes than diabetic patients without CKD? So if that is the question, your disease is retinal changes, and your exposure is actually CKD, because you're trying to see if both the patients have diabetes. You're trying to see if CKD makes it more likely to have the retinal changes than absence of CKD. In that case, you can do the study whichever way you want. It's just that this is not a rare disease. So, why do you want to do a case control study? Try to take, as large a database as you can and look at retinal changes, those who do not have retinal changes, and treat the, presumably all of them with diabetes, and treat the CKD and other confounders as covariates rather than do a case control study. I would strongly suggest that you do not do a case control study, if that is your question. On the other hand, if you're looking at, some weird retinal disease that you've got only 10 patients in, and you want to see if this, very rare retinal change is present more likely in CKD diabetes or not, then a case control design would be powerful.
Deepak Tood is asking, if you conduct a prospective non-randomized study to compare 2 different drugs that are already in use, would it be an interventional study or an observational cohort study?
It is still, so again, there is an intervention there. And like Krishna's question, it's sort of a question of semantics. But if you are conducting a study like that, let's say what, ICMR did, if they are asking if they're asking healthcare workers to take this drug, what is leading to that decision, saying, hey, you should take this drug and you should take the other drug? You should take hydroxychloroquine, whereas you should take hydroxychloroquine with azithromycin, as an example. What is that decision? On what basis is that decision being made? And if that decision is being made very, there is often some factor that is related to that. Maybe there is azithromycin available at one place, or zinc is available at one place and the other place doesn't have it. That's just going to make your results extremely confounded. So it is an intervention. There is no question it's an intervention, but it's not a randomized intervention. And that is why it becomes a very tricky thing to analyze. So to answer your question quickly, yes, it is an interventional study. But why would you do an interventional study like that when you could instead randomize these patients?
Divya Bajpai is having a question regarding one of the slides. Should the table 1 have p-value in cohort study if we identify 2 groups?
Absolutely. So I'm sure she's heard, Divya has heard other things from me in other settings. If you are doing a randomized control trial, you should not have p-values in the table 1. If you look at the New England Journal of Medicine, they have smartened up and they have no p-values. The p-values in table 1 in a RCT are confusing because if you have a large enough RCT, some of those p-values will be significant. It doesn't mean anything. What is the hypothesis you are studying? Whereas in a cohort study, you do want to have p-values because you do want to see what is going on. Which are the patients who are getting exposed and which are the patients who are not getting exposed? What else is going on there? You want to identify the covariates. So, what you think about in RCTs is completely opposite to what you think about in an observational studies. You explicitly do want to have p-values in a cohort study in the table 1.
Subal Pradhan is asking whether we need to have a sample size calculations in cohort study.
So sample size question is very tricky, right? Even for RCTs, if you ask a very smart statistician, they will say, collect as many patients as you can afford. If you can afford to collect a larger number of patients, go ahead, collect a larger number of patients. And that's for RCTs. You can do all sorts of sample size calculations. And if you talk to a wise old statistician, they will say most of the times these are made up because what you need is a minimal clinically significant difference. Is 10% decrease in end-stage kidney disease significant? Or is 20% significant? Where do you come up with these numbers? Right? Is 20% important? Yes, 20% is hugely important if we can prevent kidney disease. Is 10% less important? I would say even 10% is important. And then is 5% important? Yes, 5% is also important. Any percentage decrease is important, right? How do we pick that line in the sand where something is important and something is not important? So many of the things that we do, even for randomized control trials with sample sizes, is a little bit arbitrary. So keep that in mind. For a cohort study, hence, I would say, have as many patients as you can. If you can have 500 patients, then have 500. If you can do 1,000 patients, do 1,000 patients. The more number of patients you have, the more number of covariates you can examine, the more number of outcomes you can have. So have as large a sample size as you can without, getting paralyzed.
There's a question from Deepak Dod again. Basically, he has explained that his intention was to compare 2 regimens of treatment for steroid-dependent nephrotic syndrome, but he does not have enough number of patients to conduct an RCT. So, if he groups these patients by their preference and compare the outcome, what type of study it would be? And do I need to calculate the sample sizes beforehand?
So, for steroid-dependent nephrotic syndrome, before you do any study, find out what others people have done, right? Because a lot of people have done a lot of studies on this. If you're doing it prospectively, it's even if you don't have enough sample size to do RCT. What you're trying to say is that you don't have enough sample size to do an RCT powered for the clinical outcome that you need, which is okay. Even if you don't have a clinical outcome of, relapse or the frequency of relapse, for example, or remission or what have you, still an RCT will be better than a prospective control study. So imagine you're doing a trial of 50 patients versus an observational study of 50 patients. The trial of 50 patients will be more useful than the observational study of 50 patients. And what can happen is you can start off as a pilot study, right? Often randomized controls start off as a pilot or a feasibility trial. So you do a randomized control trial of 50 patients. As you're doing the trial, you find out problems, right? Oh, how do you give the rituximab? Patients can, only come every 2 weeks, and some patients can come in 4 weeks. And you find out that you started off with 50 patients, but at the end of 2 years, you had, 35 patients because 15 patients were lost to follow up, which happens in real life. And even though the data will not be enough to prove one way or the other that one regimen is better than the other regimen, this will be the springboard. It will be the starting point to do a large trial. So, people say, oh, Dipesh has done this trial. And this is a really interesting idea. So now Atul wants to join him, and Dr. Rajapurkar wants to join him, and Dr. Priyambada wants to join him. And they all say, hey, this is really cool that you could recruit 50 patients. Let's all pool our resources together and do a large trial put together. And you have already worked out the kinks by doing that pilot trial. So even if it's a pilot trial not powered for outcomes, it's more valuable than doing an observational study, the way you're describing. So don't worry about the outcomes. Think a little bit broad and be ambitious, and you could start small. But if this is something that you're really passionate about, the pilot trial can go on to become the larger trial. For an example, the START AKI trial. So Ron Wald, who is the principal investigator for START AKI, we were part of the initial trial. So we did a 100-patient trial. It's published in Kidney International in 2014. So the START AKI trial, which came out like a few months after Tukaram's trial came out, we had only 100 patients. And we knew that 100 patients was not going to be enough to answer the question. But because we were able to prove that we could do 100-patient trial, we could go to the funding agency and say that, see, we could do this trial of 100 patients. Now give us money to do a trial of 3,000 patients. And then when we went to France and to Australia, they said, okay, you have looked at this, and yes, we will enroll patients in your trial because you have proved you can do this. So doing a small trial could be the stepping stone for a larger trial. And that's way more useful than doing an observational study, which will give you a biased result. It may be quick and easy, but it will give you the wrong answer. And Dr. Rajapurkar, there is absolutely right that you can get a large sample size by having a multi-center study.
Yeah, the Sindhura Lakshmi has asked, you're about to tell something.
Sorry, yeah. So I just saw Rajiv Sinha's question on the sample size for pilot trial. So there are pilot trials, and I think there is going to be a session on trials. So there are pilot trials and there are feasibility trials. In feasibility trials, we just try to see if we can recruit patients. And we are not really worried about the sample size. And it's kind of, again, it's a step, right? You do that as a step towards doing a large a definitive trial of many hundreds of patients. Before you recruit many hundreds of patients, see if you can recruit 25 patients or 50 patients. For a pilot trial, which is similar to a feasibility trial, there are some sample sizes there, but really you're not looking at the effect size. You're trying to look at, can you recruit patients? Can you implement the intervention? You're not looking at change in creatinine or change in outcomes, because you are not powered for that. So there are sample size calculations for pilot trials, but they are slightly tricky because you don't take outcomes into account.
Dr. Sindhura Lakshmi is asking for a little bit of additional clarification. She is asking, in a case control study, is it essential that a healthy control arm should be included?
So again, it depends on what your question is. If your exposure, if you're talking about, say retinopathy in diabetes and CKD, and your exposure is presence of CKD or not, then taking healthy controls means by definition they don't have CKD. So it depends on what your exposure is. So if your exposure is, let's say, smoking, and you want to find out if smoking is higher, is associated with any retinopathy. If you take healthy control, by definition, they will not be smoking. So you're not going to get the right answer. So this concept of having healthy control is not really right in a case control. You want to have some exposure present in your controls. So your controls should be from the same population as you got your cases from. So your cases are all having the disease, and they come from the general population. So as a rule, having the general population is a better control group than a healthy control. Otherwise, everything is going to be significant, right? If you take a healthy control, they won't have diabetes, they won't have CKD, they won't be smoking, they won't have high blood pressure. So everything will be significant. You won't really get the right answer, which again goes back to, choosing controls is a little bit tricky. If you choose healthy controls, they will not have any exposure, any of the elements of the exposure. If you're talking about eating eggs, or something really, if you're talking about healthy eating habits, maybe that may be useful. But more than healthy controls, you should be trying to aim for the population from which you're choosing the cases.
So, okay, there's another last question. Do we need to calculate sample size for observational cohort study also?
Yeah, so as I said, I would suggest that take as many patients as you can. There are sample size calculators out there, but none of them are on the basis of hard science. So for clinical trials, it makes a lot of sense. But for observational cohort studies, the larger your sample size, the better it is. It is true, of course, that if you have 50 patients, then it's very likely that it's not going to be very useful, or whatever kind of study you're doing, unless it's a case series. So the larger number of patients you have, the better it is. Try to collect as many patients as you can afford, is my advice.
So that finishes all the questions, and thank you, Dr. Hiramat, for an excellent presentation.
Thank you. Thanks everyone, and thanks again for the ISN for having me on.
So thank you, everybody. Thank you. Tomorrow morning we will start at 8:45 from onwards we can join, and at 9 o'clock the meeting will start. So thank you, Swapnil, for an excellent lecture. I enjoyed and also learned. Thank you, Usha, also. Bye-bye, everybody. See you tomorrow.